Hi everyone. In GATT surgery, the hardest step is often finding and safely cannulating Schlemm's canal. In this video, I'll show 12 real surgical cases with HD close-up views focusing on canal identification, cannulation technique, common pitfalls, and practical surgical pearls. This case is heavily pigmented pigmentary glaucoma. Using a straight MVR blade, a regular nasal goniotomy of approximately 2 mm is performed, taking care not to go too deep. The suture is then advanced within Schlemm's canal while being kept parallel to the expected canal plane. Visualization of the first 2 to 3 mm of suture advancement within Schlemm's canal serves as a practical confirmation that the suture is progressing within the canal. Case 2 is a case of primary open-angle glaucoma. After the nasal goniotomy, gentle pressure on the lower lip of the incision helps reveal the pearl-white reflex of the inner wall of Schlemm's canal. This is an important prerequisite for correct canal localization and subsequent suture advancement. In this case, the trabecular meshwork is minimally pigmented. Similar to the other cases, I begin the incision at the junction of the pigmented and non-pigmented trabecular meshwork. As the proline suture advances, I make sure to observe at least the first few millimeters of its passage within Schlemm's canal. At this stage, it is important not to press on the cornea with the gonulins in your hand in order to avoid corneal striae and prevent loss of the viscoelastic from the anterior chamber. If the viscoelastic escapes, blood reflux from Schlemm's canal can significantly compromise the angle view. Case 4 is a combined GATT and cataract surgery in an eye with pseudo-exfoliative glaucoma and cataract. In most cases, I prefer to perform GATT after cataract surgery. If trabeculotomy is performed first, the risk of suprachoroidal effusion during phacoemulsification may increase. On the other hand, if phacoemulsification is performed first, iridocorneal angle visualization during GATT surgery may become more difficult because of corneal epithelial edema and blood reflux from Schlemm's canal. Therefore, the decision regarding which procedure to perform first is ultimately left to the surgeon's preference. Case 5 is a case of post-keratoplasty steroid-induced glaucoma. The main challenge when performing GATT in eyes that have undergone keratoplasty is achieving a clear view of the angle. In such cases, epithelial debridement may be performed to improve visualization. If preoperative gonioscopy shows peripheral anterior synechia in the angle, the likelihood of GATT failure is quite high, and tube shunt surgery is usually the more appropriate option. Case 6 is a case of pigmentary glaucoma with low iris insertion. In some eyes, the iris root may be positioned higher or lower than usual. In such cases, accurate localization of the trabecular meshwork requires clear identification of the scleral spur. Otherwise, the risk of creating an inadvertent cyclodialysis cleft increases. Case 7 is a case of late-onset primary congenital glaucoma with a diffusely pigmented angle and angle dysgenesis. In eyes with angle dysgenesis, identifying the scleral spur is unfortunately not always possible. In such cases, the target is approximately 1 mm below Schwalbe's line to estimate the location of the trabecular meshwork. After the incision, the pearl-white inner wall reflex of Schlemm's canal should be sought to help confirm the correct plane. Case 8 is a case of early-onset primary congenital glaucoma. In infants, as in this case, the angle is usually completely non-pigmented. In such eyes, Schlemm's canal is often located slightly more anterior than expected. Starting just below Schwalbe's line, stepwise incisions can help identify Schlemm's canal. The final 4 cases are standard GATT procedures performed for primary open-angle glaucoma. I included these cases intentionally to help beginners become more familiar with the gonioscopic view of the angle, the ideal incision site, and the appropriate incision width and depth. Repeated exposure to these more straightforward cases may help develop a better sense of the correct surgical plane and improve confidence during the most delicate steps of the procedure. Please also note that I do not create a bulb at the tip of the 5-0 proline suture, I simply blunt the tip. This detail is important because even when the incision is made in the correct plane, the suture must still be introduced gently and in a direction parallel to Schlemm's canal. If the suture is not properly aligned with the canal, it may be misdirected into the suprachoroidal or adjacent tissue planes instead of progressing intracanaliculi. In such situations, the characteristic blue silhouette of the proline suture will not be visible advancing within Schlemm's canal. For this reason, the initial goniotomy and the first placement of the suture into Schlemm's canal represent the most critical phases of GATT surgery. Success at these stages depends not only on the incision itself, but also on proper surgical orientation. Adequate head tilt and microscope tilt must be carefully optimized so that the angle is directly facing the surgeon and the trabecular meshwork is viewed head-on. Only under these conditions can the anatomy be interpreted accurately and the correct entry plane be identified more reliably. One of the most important warning signs of an incorrect incision plane is the appearance of marked hemorrhage in the angle immediately after the incision is made, which should alert the surgeon to the possibility of improper tissue entry. Another practical point is to avoid making the incision unnecessarily deep at the first attempt. A controlled and conservative entry is usually safer because the plane can always be refined step by step if needed. It is also helpful to follow the first few millimeters of suture advancement carefully, as this provides immediate visual confirmation that the suture is truly progressing within Schlemm's canal. If this early advancement cannot be appreciated clearly, it is better to reassess the entry site and angle view before forcing the suture forward. Thank you for watching this video so patiently. I hope it will serve as a useful guide for glaucoma surgeons who are just beginning their journey with GATT surgery.